So welcome to NUR203 Pediatric Nursing. You guys have worked hard to get here. You've done all your prereqs. You are this semester and most of you next semester, and you'll be registered nurses. And this is the semester where you start to think, start to put things together, take in information and apply it. You're going to learn all of what things are, but it's just not what they are. It's now saying, okay, I know what that is. I know what this is, which is the best answer that works with all of the above. So I'm going to try to help you think, and I do that through the Kahoots that I do every week with you. So tonight, we're going to do the orientation PowerPoint. You're going to see it in the community too. It's by Dr. Brown. It just shows you what your requirements are. Then I have a PowerPoint. And I want you to know these PowerPoints, I make sure all your key information that you need is there. Those concepts that you're going to see again. And then I have a Kahoots. I do a Kahoots because I feel that repetition of information is going to help you. So starting next week, when you come to class, do your interactive PowerPoint. This is going to give you an introduction to what the information is. Not that you have to understand it, because it's the first time you're looking at it, that I'm going to teach it. I'm going to give a PowerPoint. I'm going to teach these concepts. And then right off the bat, you're being quizzed. And most of my Kahoots are 40, 50 questions. So not only do I give you these questions, I'm going to explain them and why those answers are the correct ones as we get there. Try to make you think, okay? Put A and B together and get C and D, okay? I'm going to try to help you do that. This week, all you have to do is discussion question. Make sure you know it's a two-part component. It's not just tell me about you, why you want to be a nurse, have any questions, but it also talks about cognitive and developmental delays due to nutrition, and then community sources that are there to help. Because the one thing all about pediatrics is nutrition, nutrition, nutrition. If you don't feed the mind, it can't grow. It cannot become all it can be because it doesn't have the fuel and the energy to do it. So nutrition is so important. So that's your first discussion question. I read discussion questions. I will give you input. I will give you a little bit more information about the subject to make you think a little bit more. So always go back and look at the discussion questions when they're done. Remember, it is APA, which means I want a reference. You're not an expert. I'm not an expert on pediatrics. Where did you find that information? Your book, Perry et al., 2022. That is your best reference. It's your book. And then make sure within your paragraphs, you put the citation, Perry et al. 2022 in parentheses. That shows me, okay, you've got that information. It came from the book or came from something else, whatever you want it to do. So those references are very important. It's part of the grade that I look at also. Next week, you have your first quiz due. Do not do a quiz until you have class. Now, do I give you a quiz of a quiz? No. What I'll do is I will make sure during my lecture, you get all the answers to all the questions. Okay, so after class, you should be more prepared to do the quiz. I mean, next quiz one is a lot about theorists. So I am going to be sending you a handout on theorists so that you have a concept of them. Some of the Kahoots questions tonight are on theorists, and next week I'll be going on them as we go through each developmental stage, infants, toddlers, and preschoolers. So I'm going to keep reinforcing. I'm going to try to make it understandable. I don't teach big, long concepts. I make it easy, understandable, that you can understand and use it, because you don't have to understand those big words. You need to understand, what does it mean? How does it mean to you in a manner that you're going to remember it? And I've had students tell me they could hear my voice when they were taking an exam. It's just the way I explain things. So listen to lecture. I will also send you all my recordings. I do have a YouTube channel. It is Professor Bogart's Pediatric Nursing. It is public. You could go in there whenever you want. Any lecture I've ever done is there. And there also is a dosage calculation review in there. I make dosage calculation so easy, and it's not dimensional analysis, but I make it so simple. I also have handouts with it. If you need them, let me know, and I'll send you the handouts if you want to look at the dosage calculation, all right? And I think with the first week, I'm going to send it to y'all because we know every single exam is 5 questions. And I want you to get, they should be all 100%. That should be a given to you. And I know MedSurg has harder ones. So I will make sure that you understand like per kilo per minute. It is really easy. I think many professors make it so difficult. And the way that I break it apart, you're going to go, that makes sense to me. And that's what students do tell me about it. So during class time, I will go straight through. I try to get you out early. That's my goal. I mean, do we need a break? Well, no. If you have to go to the bathroom, go to the bathroom. If you need something to drink, get something to drink. It's 8 o'clock at night. You just get home, you need to eat. Please eat. Don't feel like you can't in front of me. I understand you have a life beyond school, okay? So just communicate with me and I'm okay with what you have to do, okay? Any questions? All right, let's start out with the one that the PowerPoint that Dr. Brown's sent, and you're also going to see this in community when you get to community if you haven't already. I'm going to make it very brief and to the point here. So basically what this tells you is that you have a responsibility, and so do I. Just make sure that you get your homework and assignments done. So have any problems, you have concerns, your case study didn't come over into the grade book, you can't get your case study because your kid's in the hospital, you're in the hospital, your mother's this, that, I mean, life. Let me know before something is due. I'll work with you. Don't tell me after, because you know before it's due, something's happening to you. I am going to give you my cell phone, and you use it for emergencies, not for everyday chatter that you could put in a message, because I answer very quickly on your emails and on your Canvas messages. So if you need me immediately, something's going on, or you want to tell me before class and you just found out, my number is 305-951-8055. This number is also in the welcome biography, so you have it there also if you do need it. Now, in any course, you have your professor, you have your lead, and you have the dean. Well, I am lead professor of the pediatric program, so I am the first person you're going to go to because I'm your professor. Now, something's going on, I'm not answering your questions properly, or you need something quicker, I'm not answering for whatever reason. Dr. Brown is extremely accessible. I don't mind you going to her if you need something. She'll just get back to me. She has other ways to get to me. And I don't know, sometimes she can get to me when I don't even know I could get a hold of. So call Dr. Brown. Here's her phone number, and that is her email. If you need to, whatever, please reach out to her. I do not mind. Now, remember, it is professional. Try to come to class, you know, in something that you're not, you know, too bare of a skin, you know, make sure, you know, you're professional enough. And when you come, remember, there's other students here. During any lecture, if you have a question, stop me. That, I think, is something that if you have a question, somebody else does. I don't mind you stopping me for questions. That is, for me, professional conduct, because you don't know it, okay? Always remember, this still is a classroom environment, you know, and to try to be, you know, as professional as you can. Now, when we have new assignments, there are going to be open on Monday at 12 a.m. So next week, the quiz opens at 12 a.m. Monday, okay? And that's Pacific time, which is 2:59 Eastern time. Just remember that if you're that night nurse, that night person, that somebody, you know, who works a night shift. I did 23 years of nights. I love nights. Just remember that, because some of you like to go on break and get some stuff done. I get that. I understand it. Discussion questions are Wednesday night, they're due, and then you have to have it posted to 2 peers by Sunday. I usually will let you know you haven't posted yet, to let you know, especially towards the end of this semester, because it's going to get pretty busy, and you'll understand when you get there. Now, homework. It's due on the due date due. If you call me before because for whatever reason, your internet went out, there was a snowstorm, you moved, it hasn't been connected yet, it's too late, Starbucks is closed and so is the library, there's nowhere for you to get internet, and it's going to be late, let me know before it's due again. That's all I want to hear. Then I will give you another day to get it done without a 10% deduction. But if something is due, it's not turned in, that second week is going to be a 10% deduction. If you get 100, it's going to be a 90. After 2 weeks, so it was due this week, you have 1 more week and you don't get it in, it's going to be a 0. And unless it's been pre-approved, something, is going on, you've been in the hospital, something's happening, it will be a 0. Be careful. Subjective grades, your homework grades, can affect you. And last semester, I had a student fail because of homework. Okay, as much as please get it in, this is a lot of percentage, please, please, and it wasn't handed in. So be careful. Now, one of the things with online I want you to be aware of, taking attendance is not you with me. That's not considered attendance. The attendance is when you go in and you sign your attendance attestation. At the end of every class, I'm going to remind you to do it, okay? But if you don't do it, I will be sending you reminders. But that is one point of contact in Canvas. Now, this week, your other point of contact is your discussion question. 2 points of contact every week. If for 2 weeks there is no posting, nothing going on, they will drop you and they don't have to tell you, okay? Be very careful with that. I don't want anybody dropped. And I had this one student was sending stuff in to another professor by email and not in Canvas, and they were dropped. So it does happen. Remember, you don't sign in, you weren't here, okay? So please take credit for what you're doing. These weekly sessions are mandatory. If you can't make it for some whatever reason, please let me know. If it is in a rare occasion, one-time occurrence, I can have you come to another class, or you can watch a recording and I'll give you a couple questions for you to do about the lecture. But be aware, those questions I'll ask you are those concepts you really have to know, because you're going to see them on quizzes, exams, and essays, okay? So it won't be just little work that's just busy work. It'll be something that will help you, okay? NCLEX questions, remember, you can do them over and over again to get your best grades. And this basically just says, make sure you get your work done. Log in, check, see what's going on with you. Take your syllabus, print it, or if you don't like printing, have it saved so that you can look at it to make sure what's due, because your syllabus is your Bible. What it says it's due, that's when it's going to be due, okay? And then whatever you do, make sure you write down your assignments. I like paper. Some people like to just put it in their phone, this assignment due, these dates, whatever works for you, you go ahead and do it. When you come to class, make sure your computers are plugged in, because I do Kahoots, make sure your phone's plugged in, you have plenty of batteries so it won't run out for those sort of things. If you're having a thunderstorm, snowstorm, possibility, internet's gonna go out, just let me know. You're gonna hear me say communication is the biggest thing. Let me know what's going on and I can work with you. You don't tell me, I don't know, okay? So please just communicate, that's all I'd like. I'll do review sessions if you want. You have to ask. If you want one-to-one tutoring, just ask. I will work with you at a time that is good for you. I have other classes. I'm teaching 4 classes this quarter. So if you need me to one-to-one, you don't understand this or that, you want to review before an exam, whatever it is, I will work with you, but you have to ask, okay? So if you need extra help, it is something that I will work closely with you, okay? And I do know those students who've had issues and immediately realized it came to me, they did well. So please make sure if you need it, ask. Your grade is on your objective and your subjective grades, your objective, exams, quizzes, and your HESI. Once you get a 78.0, they will add in your subjective or your homework grades. Now, your homework grades can affect you positively. You can have a 78 go to a B, or you can have a 78 go to a 70 and you could fail. Homework grades do fail. The one thing I tell you to be aware of is that pediatric assessment assignment. That pediatric assessment assignment is worth 6% of your homework grade. I did have a student fail more than once because they didn't turn it in. So please, let's work with that a pediatric assessment assignment. I'm going to get into it as soon as we get it in this PowerPoint. Homework grades I keep off and then I turn them on. I'm going to show you how they'll affect your grades. Then I'm going to turn them off for the rest of this quarter. And then after we get our remediation to HESI in, I'll turn them on. And that will be your final grades. All right. Now, there is quizzes. As I said, the first one is due. Starts next week and it's due a week from Sunday. It is timed. It is 15 minutes, 1 question at a time, only forward, not back. What happens if you get up, go to the ladies' room, come back, and your 2-year-old daughter had pushed buttons, finished your quiz, and it's locked out? Immediately let me know it's happened. I've had computers where the dog chewed the wire, something happened and they couldn't get back into it and it timed out. I've had crazy things happen. So when you're doing the quiz, make sure you have that 15 minutes to sit there and quietly do it and get it done. If your internet clicks because all of a sudden there was an accident and the internet was knocked out, immediately on Canvas or an email, let me know. There are timestamps on the quiz. I know how long you've been in each question. I know what answers you've chosen. So please immediately let me know. And then I can reset quizzes that I know what's happening and I've been told right away, okay? ExamSoft is going to be, again, for all of your exams, and it will be through Zoom. The only thing I'll tell you is make sure you come with all charged equipment so that you don't have to go running for your cable and stuff during exams, okay? I used to, but I cannot because the dean told me I can't give grades early. We have to wait till they're all in. My last class on Fridays is 10 o'clock Friday night. So your grades, unfortunately, will not be until Saturday about noon, okay? Now, if you are having, you're like, not even really the first exam, but the second or third, you're like getting really nervous. I can tell you you're okay, but I can't tell you a grade, okay? If you have accommodations, let me know. If you need more time, because I have to give you more time on your quizzes and on your exam. I need to know before the exams are due. So send me a message in Canvas, please. We know the Zooms is proctored for all exams. We know all about that. And late work policy, you know all about it, but with exams. Now, there are times when you can't take an exam. Let's say you had COVID bad. You can't take an exam. You tell me before the exam. You can take that exam up to a week later, but after a week, it has to be some extraneous condition, reason why that you can't. And I will not take off 10%. But if you don't show up the day of the exam, no prior notice, you need to take it within a week. But again, it's minus 10%. And you don't want any exam minus 10% of your grade, okay? Again, can I tell you some more about communicating with me? Communicate with me before, not after. Homework assignments, again, make sure you know what you're doing, write it down, know when they're due, get them done. I'll tell you every week what is due. We know the late assignments. First week, it's going to be good. When it's over, 1 week due, that's when we get a minus 10% grade, unless you've told me about it. NCLEX questions must be turned in the proper format. If they're not, I will give you an instruction guide in your NCLEX questions under comments. So you'll have it if they're not. Most students are pretty good with this, but if they're not, I'll let you know, and we'll communicate and get it done. Again, try to get the best grade as you can. You don't have to take your first set if it's 30 out of 50. I would want at least a 40 passing grade, right? At least that, if not higher. Screenshots are not acceptable for anything in this course, whether they're NCLEX questions, case studies, Kaplan, I don't accept any of them. So you can keep them just to be safe, but I won't accept them. It's something I can't. Case studies you must do through the modules. And again, it's first attempt only. So as you're doing them, spend time, to look at the answers and pick the correct one and get the best grade you possibly can. They should go immediately into your grade book. If they don't go into your grade book immediately and it is done, send me a message. I'll look to see if I can find it. If I can't find it, I'll have you do a help ticket. But that's something, again, with communication between you and I. Now, discussion questions, papers, right? That's to be done APA. Now, week 8, you have a pediatric assessment assignment due. You are going to choose your own pediatric diagnosis. It could be cystic fibrosis, diabetes, cerebral palsy, Down syndrome, asthma, urinary tract infections, Hirschsprung, rheumatoid, whatever you like. Now, what I suggest you do is choose a diagnosis maybe you have ADHD, as a child, or maybe you have a child like that, or autism, or you want to study something a little closer because you want to learn more. And when you do that, let me tell you, some of these assignments are really, really awesome. It is a 3-part thing. You have a paper and you have a handout. It's a pediatric assessment, and it's going to go through each of your systems. If it is, let's say, a paper about asthma, let's say childhood asthma, under respiratory, please put what an asthmatic child would look like if they're having an asthma problem. You're not going to say lungs clear, breathing easy, because that's not asthma. And then in other things, don't put normal. Don't tell me within normal limits. Well, do you have a heart? What does it sound like? Is there a murmur? Is it regular? Okay, do you hear what I'm saying? I want to hear what those systems sound like. And the third part is a teaching tool. Teach me about maybe using an inhaler, preventative asthma, or cystic fibrosis, about the aerosols that they take, or diabetes, how to give an injection, what diet, how to monitor blood sugars. There's so many things you can do teaching tools on. Most students do pick PowerPoints, and I don't want a 30, slide PowerPoint. Give me 5 slides, tell me about something, but make sure you put references on it to tell me where you got the information from, please. And there is a rubric there that helps guide you. Again, we know it's going to be APA. So we know about the quiz already. I've told you about it. If you have problems, again, just let me know. Now, Kaplan, it's not due to the end of the semester. This is one of the things that is open for you. You can do it whenever you want. There is a math and there's pediatric A, B, and C. Don't send me a screenshot. I am going to be going into each campus and each student, and I'm going to find your grades and I'm going to put them down. And I'll give you a hint. Most of them are due on week 10. All of your A, B, and C's are due week 10. The math is due week 9, but I'm not going to look till week 10. After week 10 is due, I'm going to go do all the Kaplan. So that math, if you're a little late, and I'm telling you, you're going to be doing a lot of stuff in that week, If you do it that week, I will accept it as okay. If you're doing these things and you don't remediate, it's going to be half of the earned grade. So what your goal is, 1 to 2 minutes per question remediate. And then I've had students tell me, well, why am I remediating answers that are correct? I got 100. Why do I need to? Well, you could have got 100 because you knew it. But what if you had some doubt in your mind about something? You remediate it, you read about it, you're going to go, oh, all right. And then it's going to stick. It's going to be better for you. That repetition again of information, and it will help you. So if you do your Kaplan, get the best grade, you do it many times as you want. I don't care. I've seen students do each one 3 times. It's fine. I would want the best grade too. But on your best one, do your remediation so you get your full grade. Your HESI is going to be a week 11. I do have some really good HESI review material. I do have 2 Kahoots that I have made that both sort of repeat a lot of different things or look at different concepts in different ways, and students do well with it. We also have a good PowerPoint that has a lot of the great information in it and a lot of questions, that we put into that Kahoots. And then the third thing that you should use is the NCLEX pediatric section. It is really good and it actually fills in the holes or maybe the understandings. I've had students 99.99 on their HESIs, and they tell me it's the Kahoots, the PowerPoint, and the NCLEX book is exactly what they studied. So you have all the information there for you. And, I would do my best on the HESIs because honestly, I want to do 1 hour of mediation, not 4 or 6. I mean, that is a lot of work on remediation. And remember, it's 20% of your grade. So try to get the best grade as possible. Usually my students, if they're following, keeping up, watching the Kahoots, understanding them, and then doing okay on the exams, do very well on the HESI. So keep up with it week to week. We know all about showing the ID and all that stuff, and then, being prepared whenever you're doing anything. Any questions? Okey-doke. Let's do our week 1 PowerPoint, okay? Remember, anybody who needs an answer to a question, stop me. It's all right. I don't mind.
Ms. Bogart, I do have a question.
Sure.
So you said you don't take screenshots of the NCLEX. So how do we submit those to you?
Shawnee, I'm going to send you something.
Okay,
I have an instruction sheet.
sounds good. Thank you.
No, you're very welcome. It's very easy. When you get that point where it says resulted on that page with the little green box, the bottom right-hand corner says an area that says to print results. As you're going to print it, you change to PDF and you save it and send that. But I'm going to send you instructions too. It's as simple as that, okay? So yes, I'll send that to you tomorrow. Yes, ma'am.
So I don't know if you had already addressed this, but I have not had any communication about the simulation portion of the class. Will that come out later or?
Okay, simulation is done on campus. So go to your simulation coordinator or the dean. Where are you from?
Westerville, Columbus.
Westerville. So you're Cookville, right? Or is it
Columbus?
Columbus, okay.
Mm-hmm.
All right, actually, I've been working with your simulation person there very closely. She was new last semester. Yeah, go to her and she'll tell you when. There is 4 simulations that have to get done, 5 simulations, 4 or 5. Okay. I'm forgetting, oh my goodness, I used to teach them. And they'll tell you when and they'll fit them in, just like clinicals. Those are for campus. I don't know 16 different campuses and the schedules, okay? I just don't. They don't send that information to me. But thank you for asking that, because I know somebody else who probably wanted to know too. They're actually quite fun if they're done right. I enjoy them. I used to have a lot of fun teaching those. Okay, healthcare for children. Now you think of children, this class and the classes that I teach are pretty lucky because I actually taught I actually did adult ICU ER nursing before I came into pediatrics. So I literally know the differences between pediatric and adult diagnoses. And I know most of you are in med surg too right now. So I can tell you what the similarities are, what the differences are. And I can actually, because I know that, it will help you in med surg too. So that's as we get to the systems of the bodies and those diagnoses with them. So with children, most of the thing, it's all about health promotion. You know, as you go into your higher level degrees, you're going to be doing papers all about healthy people 2020. And all it does, there's different things they look at, children and elderly and all different things. And they want to make the population healthier. It used to be Obama was talking about, you know, getting out and exercising to prevent obesity was part of it. And that's all because of, you know, she saw a big group of children, an epidemic actually of, you know, children getting obese because they're not up and moving because of all of the electronic devices they have to use right now. But the one thing I'm going to talk about is Healthy People 2020 is all about nutrition. You know, nutrition. If you don't feed the mind and the body, it's not going to grow and develop the way you should. And if your teeth are rotten, you're not going to want to eat because it hurts. So then what's happening? You're not getting nutrition you need. So nutrition is the most important thing when we talk about children. And as I told you, obesity is a big thing. You know, children are getting injuries, of course. They just have no filter. They just go out and do what they want, and they don't think about what's going to happen to them. As they get older, we're going to see that violence and bullying through school. And then, you know, children and mental health problems, you're going to think, children? You know, I've actually seen a 6-year-old with paranoid schizophrenia. And this child, you could see all those things exhibited in the child. So children do have mental health problems. I mean, many of it's depression, that's a big one, but there are some of the other diagnoses too. I think these pictures tell you a lot about all the injuries children. You know, I live in South Florida. I live 30 minutes from the Florida Keys, and I have a pool in my backyard. I have a grandson who, for the first 3 years of his life, lived with me. And with the pool in the backyard, I was really scared. So by age 2, this kid was doing front flips in the pool and swimming. He knew how to get to the side, put his hands up. And I'm not talking with floaties. I'm talking the kid could float on his back and he could get himself to the sides of the pool, and he knew how to keep safe. The other thing is he wouldn't go in without asking first. He did it one time. He went in without asking, and he was ripped right out of that pool and sent right to timeout. And he realized how serious it was. So to this day, and he's almost 6, he's 6 in January, so he doesn't do it anymore. So water safety, you know, the burns on the stove. I have an older brother who has a burn down an arm. He pulled something off of the stove. We know those bags, the kids will suffocate for sure. And of course, any medications left around. I think the biggest thing kids eat is vitamins. Those Flintstone Chewies, they love them. And actually, they're the most benign of all the things. So when they get into the Tylenol, which is the bad ones, or things with too much iron, and the iron can hurt them too. Highest risk children are those that are born really small, premature, very low birth weight, and low birth weight children. Now, these children have to be born, their lungs aren't formed, their body systems are immature, and they go through all sorts of medical issues and sepsis, and, you know, so they are born and they're very high risk. Those children that go to daycare, you know, I call children who go to daycare, all they do is swap spit, right? They have all these toys, and it goes from kid to kid and from mouth to mouth and all the way around. And it's really hard not to, or to prevent that, because that's just what kids do. I mean, how do kids explore their environment? And it is said through their mouth. Everything goes into their mouth. And that's actually how they self-soothe, is by their mouth. You know, as in infants with a pacifier, or with their fingers, their thumbs, or the toy or the blankie, whatever it is, everything is in the mouth. Children who live in poverty and are homeless. I mean, we know today most people are one paycheck from being homeless. It is really a serious issue, and we have to remember that some children are homeless, and how do we work with them? They don't have money to go to the doctor. They don't have money for food. They have no money for medicine. So that is a big health problem. Immigrant families are afraid of being deported. I mean, I live in Homestead, which is South Florida, which is a lot of farmland, and there are immigrants here. And these families don't go to the emergency room unless the kid is very sick, because they're afraid of being deported, which that's not a nursing job. We take care of the patient, not the immigration problem. Kids with chronic medical and psychiatric illness and disabilities, of course, they are always, immunosuppressed and up, for more health problems. And we know there are barriers to healthcare. It could be as simple as no transportation, or they don't have that $5 copay to get into the doctor. So that is a barrier. Infant mortality, first year of life, more, we call it infant or postnatal or neonatal mortality, okay? The United States, the big United States, you'd think that we would have one of the lower numbers. We don't. We have a higher number of infant mortality. Other countries tend to have better prenatal care and care for deliveries and better health care for the mothers too. So many things need to change in the United States. Now, in the many years I've worked in the newborn ICU, because I've done newborn ICU, I've done cardiac ICU, pediatric ICU, and the last 10 years was the pediatric emergency room, and I was a trauma nurse. So I have a lot of experience, with it, but I know there's been advances, but there still needs to a lot more being done. I mean, the birth weight of these children, I've seen as low as 485 grams, I think it was, and that's less than 1 pound. And that child had bleeds in the brain, and the intestines died, and NEC and colostomies and sepsis infections. And, in the end, after a couple of months, the kid did pass away, but it's because of low birth weight. As the kid gets older, the death rates do decrease. I mean, we know those toddlers, ages 1 to 3, I'm going to call them the dive bomb kids. They go from the couch, they want to go to the other couch, and they jump, and it's too far, they miss, they land on the tiled floor, and they crack their head, and that's just what they do. Those are toddlers. They don't have any sense of what's going to happen to them once they do jump. They just want to get there. And then, of course, as they get older, it's going to decrease the death rate. Now, mortality does increase as adolescents, because adolescents try to be more independent. And you're going to see injuries, you're going to see more homicides, and of course, with body image issues and those growing pains as adolescents, increase in suicides. So talk about family and children. Now, many people, nurses, don't want to work with pediatrics. And the main reasons is they don't want to work with the parents. Parents can be hard. They can be difficult. They used to give me the difficult parents all the time. I'm like, can you give me a break, please? They go, but you do that so well. And what do I do differently? Well, number one, I realize they're worried, they're scared. They're here in the hospital with their children. They want to be a part of taking care of them. So I will incorporate what I'm doing and let the parents do a lot of it. I put them to work. I tell them what to look for so that they're helping me take care of their child. And you know something? That's all they want. They want to take care of their child. They want to be a part of it. They want to be educated. So that's what I do. You know, family is that one constant in that child's life. So to kick the parents out because they're difficult, it's not going to do anybody any good. Those children need those parents. So as a nurse, sometimes you've just got to, how can I make that parent happy? And how can I have them help me help the child. And that's what I did. You know, I've met lifelong friends of children and parents because of the way I work with them. Family is whatever the family says they are. There's all different sorts of families. I mean, here we go. Traditionals, we have nuclear, blended, extended, single parents. We have LBGTs, mothers and fathers. We have all different sorts of families. You know, family is whatever the family says it is. It could be grandma and grandpa. It could be adopted. It's okay. Family is whatever that child knows who it is. Now, more than ever today in pediatric nursing, we're trying to provide atraumatic care. Has any of you ever gone to the emergency room lately, need an IV, and they just take it and stick it in and they don't numb it, do they? And it can hurt. On children, we don't do that. We will numb the area first to do as minimal pain as possible. Atraumatic care. Why do we do that? Well, ever have a 6-year-old see the nurse walk in the room, they run out the door, down the hall, and out the exit. And we're yelling, security, catch that kid. Because it happens. Why? They're afraid. Why are they afraid? It's because of all the pain that we've inflicted on them during the years. It could have been a one-time thing, but that's all the kid remembers. So as possible, least amount of pain is possible. I use a lot of distractions. I have a lot of stickers, bows, ribbons, you know, I'll put music on. We have people that can help us with distractions, like with iPads and bubbles and toys and whatever I can find, I'm going to use to keep that kid calm so that I can draw blood on them. I can do a catheter, urinary catheterization, and they're not going to be afraid because of the way I set it up. Now, another thing we have to think about as pediatric nurses is cultural health beliefs. Now, each culture has different things they believe in. You know, they have special food, clothes, medicines, you know, they have rituals, the medicine man, all different things, you know, prayers. These all things we must let these parents have and the children be a part of. You can't stop that. That's part of their culture. Some of their health beliefs is, you know, what causes the illness? Was it that they were outside in the rain and that's why they have pneumonia? I mean, some people think you get wet, your hair get wet, you go outside, you go to sleep with hair, you're going to get you cold, you're going to get sick. That's just part of a belief, okay? It could be to the point of voodoo, witchcraft, evil. Those things could be it too. And then there's what we call the hot and the cold imbalance. Now, in South Florida, I work with a lot of Hispanic patients, and they believe, especially grandmas, we call abuelas down here. I'm an abuela because my children is half Cuban, so I'm an abuela, but I don't believe this. They believe that if you walk on a floor that doesn't, you don't have socks on your feet, that your feet are going to get cold and you're going to get sick. It's part of that hot cold thing. Now, I've had to turn abuelas around, grandmas around and say, you know, your kid has a fever and we need to get that fever to go away. So if you don't put socks on that child's feet and they step on that cold floor, what is it going to do? It's going to pull that fever out of the child. It's actually good for that child, you know, to let the air out, you know, and let them step on the coolness. It will help them feel better. They don't want to give them cold drinks. And I'm like, please give them cold drinks and popsicles. Putting that in them, again, it's going to bring a fever down. So teaching and re-educating in a manner that they understand helps. But understanding they have these beliefs, it takes time. Many times I've asked many questions to many cultures, you know, and that's how I've learned the things that I've learned. Now, we know religion is many people's, it's one of their biggest priorities. And something that we really, as nurses, depending on our religious beliefs, have to understand. When you have a very sick, let's say a really sick newborn is admitted, and we don't know the outcomes, one of the things I do is ask them, do you have any religious services you want to do? As in a baptism. I don't know all sorts of things that all cultures do, but I'll ask the parents, is there something we need to do? Is there a rabbi, a minister, a priest, whoever wants to come in to do something with your child? What do you believe in? Another thing that I've had to work with is Jehovah's Witnesses and blood products. They do not believe in administering blood. Now, in newborn ICU, we know that newborns do not start making their own blood till about 3 months of age. So those cells die. Plus, we're taking blood for specimens to monitor, their hemoglobin hematocrit and their electrolytes for many different reasons. Then all of a sudden their hemoglobin hematocrit are maybe say 6 and 18, 5, 15, and they're starting to get symptomatic, which means they're not breathing good. Periods of apnea and bradycardia shows that they're symptomatic. Well, we can go get a court order and we can give blood to these patients, but how you give it is how you respect the family. Now, I've worked day shift and night shift, and I've had to give blood to a Jehovah's Witness child. What I do at night, if I can, if the child tolerates it, I wait till the parents leave so they never have to see the blood bag. During the day, I say, could you please, would you go to the cafeteria, get a cup of coffee, give me 20 minutes, half hour, and come back. And I'll take care of everything, cover it with a blanket, don't have the blood bag hanging around so they don't see any of this blood. And I can look under the blanket and they stay on the other side of the bed. And I could check the IV site, etc. And I've administered it like that. I've had mothers thank me for doing that and respecting their religion. And I just say, I know this is hard for you. And just that I respected them in that manner really made a big difference, in the way that she felt about nursing. And they have to get the blood. It's part of, they have to, or else they would die without it, especially the premature infants. Oh, another thing is, talking about natural remedies and medicines. Many cultures believe in teas and different sort of spices that help. Now, my husband is Jamaican. When he gets sick, he likes ginger and he likes garlic and teas and all different things. And it's okay that they can incorporate that within medical treatment if it's allowed. But if it's going to hurt the treatment, you need to tell them no. For instance, let's say we were giving garlic for whatever reason. Garlic can affect bleeding coagulopathies. And if I had a problem with that, we would say, okay, you can do all of this, but don't give any garlic. And the parents will be fine, but at least you let them incorporate their culture into the treatment, and it will really help them understand and, to help you more and give you more respect also. Pediatric nurses are really, we're therapists. We really are. They've got young children. They don't understand completely, don't understand diagnoses. I've seen marriage problems, mothers and fathers. And as a nurse, you're in between all of them. And, you really do make these therapeutic relationships. Most of the time I'm teaching and telling them what they need to do, how to get the kid home, and I'm helping them to help me take care of their child, and it helps me in the long run, that health teaching, injury prevention, yes, all of that, we need to be a part of. We are there helping them, supporting them, and getting them everything they need to take care of their child properly. It's really, can be exhausting sometimes, but extremely rewarding also. So, nursing process, assessment, diagnosis, outcomes, implementation, evaluation, documentation. I mean, it doesn't matter what patient you take care of, whether it's a young or old, we're still going to always do the nursing process. So, talking about what I was talking earlier about injuries, and then talking about the adolescents. The leading cause of death among African American boys ages 15 to 19 years is, remember, injuries increase as they become adolescents due to, well, firearms and suicide were two of the big things that I just said. So the answer is firearm homicides. They just want to pick up the gun and touch it where they couldn't as a kid. And of course it goes off and somebody's hurt or they're in gangs or whatever. So growth and development. Now, children are born, let's say it's 7 pounds, an infant born. They can't even lift their head up at birth. By 1 year old, they have tripled their birth weight and they're walking. That is amazing the way it happens. I like this interrelated, simultaneous, and ongoing. It is so quick, don't blink your eyes, because by the time you know it, it's not a baby anymore. These are little young people by the time that they're 1 year old, and there's many changes. And we call this direction of growth cephalocaudal, because it starts with the head, lifting it up, caudal down to the feet and the walking. Now there's different ways of looking at development, and these are important things for you as you're doing your readings to look at. Directional trends, sequential trends, developmental pace. I mean, sequential is you lift your head up first, and then you're going to turn from back to front, front to back, and then you're going to crawl before you creep, creep before you walk. These are all things that we do. And then developmental pace is all these developmental milestones that they are making them, that they are lifting their head, they are sitting at 8 months, they're walking or at least standing at 12 months. These are all different things that we're going to look at, and things that when you're reading, look at them really close. You know, metabolism in children, as they get older, they mature. An infant at birth heart rate is of 140 to 160. Now I'm going to be sending you a vital sign sheet, because you need to know what a normal vital sign is on a child if you're going to evaluate, is it good or bad? I mean, 140 to 160 sounds like a lot, right? Well, not for an infant. That's normal. Metabolism, also their temperature. Infants at birth, they can't hold their own body temperature. We must make sure that we keep them warm, whether under a warmer or with a blanket, so we don't have them get cool. They sleep a lot, they rest a lot, with a couple little, tummy times in between, but basically sleeping, eating, peeing, pooping. That's what babies do. And again, nutrition, single most important influence on growth. And we know, according to one of the theorists, Erickson, a child who has had their needs met, which is the trust versus mistrust of infants, if they know their needs are met, it's going to be a really happy baby. So these are, we're going to go into these even a little bit more next week. Freud, everything oral sexual. Erickson is the one that you're going to see on your HESIs and your NCLEX. This is the theorist that talks about the infant at infancy, trust versus mistrust. All the needs are met. He cries, somebody comes, if he needs changed, he's changed. Piaget talks about how they think and how they have to see it, and then they start making sense. And Kohlberg is about moral. There's good behavior, there's bad behavior, and there is a consequence for each. And we really don't go into Fowler. Now, what do children do for the first couple of years of life? They play. And play is so important. It helps with that sensoromotor development. What is that? Well, children like to touch stuff, to feel it. What does it feel like? Oral. In the mouth, they explore the world in their mouth. I mean, we always know, get that out of your mouth, get it out of your mouth, put your hand out of your mouth, get the toy out of your mouth. This is part of what children do. And then, like taking a rattle and moving it and hearing a noise, that's motor. Or as they get older, the car that goes down and vroom, vroom, and they're putting the car on the, the couch or whatever and rolling it around. And this helps with intellectuals, their logical thinking. As they get older, they socialize with other children, they become creative, and playing is one of the most important things besides nutrition that children do. It helps them. You know, if you have a toy they want, they have to creep towards it. So it does help with their motor also. Now, there are types of play, whether by themselves or with someone else, or like, for instance, this dramatic play. We use that a lot in medical, where let's say a kid was abused and we wanted to figure out how and why. Some children with dolls and, you know, stuffed animals can show you dramatically what went on. And it's non-threatening because it's playing. Kids play, it's non-threatening, but you set them up in a way, they'll sort of show you what's happening on. Now, types of play, important concepts that I'm showing you right here. Onlooker, kids look at another kid play. Solitary, playing alone. Parallel play, you're both playing together, but not, maybe not the same toys, not the same way, but you're both playing next to each other. Associative play, you're playing together, but there's no goal. It's not like playing a board game where there is somebody's a winner in the end. That's cooperative play. Cooperative play is kids playing together, usually a board game, it's usually described, and there's a winner in the end. So through your readings, look through those again, you're going to see them again. As I said, toys are important. It really helps them with creativity. It's with noise, it's with muscles. It's good for the whole body. Now, when we get children, we do a couple different things. You get a child in a doctor's office, the first thing is a height and a weight. What does that do? That is measuring if the kid's getting enough nutrition, isn't it? Because if they're growing, gaining weight, they must be getting good nutrition. If they're too much, we can decrease the amount of nutrition. Not enough, we can increase nutrition, but very important. Another thing we do is looking at a child to make sure they're making these developmental milestones. If they're not turning over front to back to front by 6 months, something is wrong. What do? We institute early intervention, which is physical therapy, occupational therapy, or speech therapy, whatever they need to catch them up. And what the best thing about children is, you give them a little therapy, they catch up so quickly. They're so resilient. It's one of the reasons why I love working with children. And then you look at developmental assessments and you say, well, my kid is cognitively delayed, he has cerebral palsy. Well, there's certain assessment charts we can use for those children too, to see if they're doing what they're supposed to do. Children can be born with congenital abnormalities, you know, cleft lip, cleft palate, you know, we've heard of those before, club foot, missing arms, fingers, legs, that can happen. It could be due to an intrauterine development, which could be genetic. And we think genetics, most people go, oh, Downs is probably one of the most common of all genetic things. Or it could be due to the ingestion of some medicines. And it could be medicines that the mother needs, but didn't know that she couldn't take it because she was pregnant. We're learning more and more about these meds throughout, you know, since, I mean, my kids they're what years old? They're late 30s now. They didn't know all the drugs. Like, we used to be able to take Tylenol as much as we wanted, or any type of antiemetics. Well, we know today we have to limit a lot of that stuff. We know other stuff can cause sort of deformities in our children. Of course, drugs and alcohol, being exposed to rubella, etc. And we know that there are genetic problems. So, growth and development, children, what do? Well, we need to go and do an assessment, find out what's wrong, and we need to be there as a support system for the child and for the parents. We need to allow the child to cope and to talk about what they're going through, because some older kids will, that they're scared. Let them vent. Kids know more than you think they know, even younger ones. And then parents, they always feel guilty that they didn't do something earlier enough. I think that one unit that I saw this guilt a lot was in the cardiac intensive care unit, where you have a child born with a heart, maybe a hypoplastic heart, which is pretty serious condition in children. They feel like it was that Tylenol they took, or they had a glass of wine, they didn't know. And you say, it wasn't that glass of Tylenol, it wasn't the wine, it's just something happens during development. You did nothing wrong. You know how much that helps the parent? You as a nurse telling them that. Something that nurses, we are, I tell you, we are that person, that their therapist that helps. And many a times we are the person that says, this kid really needs to get in speech therapy. This is what I'm hearing. And it really helps that child be the best that they can be. Now we're going to start talking about different words that you've never heard of, like object permanence and pre-operational thinking. Now, B and C are both under Piaget therapist, which I said I'm sending you that handout. Something we're also going to be discussing next week. But let's go into, just showing you into it. So a father tells a nurse that his child is filling up on household with collections, seashells, bottle caps, baseball cards, and pennies. The nurse should recognize that the child is developing. Well, let's look at the answers here, okay? So it's concrete operations. Is where they're starting to be able to put things in classifications. Instead of just cars, it's cars and trucks. And if it's not cars and trucks, it's race cars. And then it's trucks and then pickup trucks. It could be all different things that they put in orders. As they get older, they'll start to be logical to sort them a lot better. It's part of how they grow, their thinking. Objects permanence is something you're going to see again. This is about a toy that a child sees. Even infants, younger infants. Let's say you had a rattle and you were rattling it and you put it down in front of them and it was partially, they couldn't see it. That kid still knows that even if he can't see it, he knows it's there and goes to reach it. As kids are older, you put away their favorite truck or doll and you put it in the toy box. Guess what? They know where it's at. They're going to go to the toy box and get it out, right? That is object permanence. So history, physical assessment. Now, HIPAA, we know, is important, doesn't matter age of the child. The one thing difference with pediatrics is the age groups. Pediatrics goes to age 21. So if you have an 18-year-old cognitively aware, a normal 18-year-old, and they go in and get lab works or x-rays, whatever, we don't have to tell the parents what's going on with that child unless that parent asks the child to give us permission, okay? They cannot call and get lab results. We have to have permission from the 18-year-old. As an 18-year-old, they sign their own consent for treatment on entrance to the emergency room. So 18-year-olds are treated like adults, okay? So that's one of those tricky situations. Well, it's my kid and I want to know. And I'm like, 18, I can't tell you. Ask your son, ask your daughter, and we'll get the backflash, but we must respect HIPAA, don't we? Communicating with parents, probably the most difficult thing there is. So many things to think about. We want them to talk, but we want to find out what's going on. Remember about that cultural awareness. Do we look at them in the eye? Do we touch them? Do we sit next to them? How do we do that? I mean, cultures are all different. Listen. And that part of being empathetic, realizing that kid who comes to the doctor's office, whose mother has been with his kid, he's been 5 days sick with vomiting and fever and cough and whatever. 5 days they haven't slept. They're exhausted. So they're coming in to get help. For you to acknowledge, oh, you must be exhausted. You've done everything right. Let's try to see what we can do. You've acknowledged that mother has done everything they could do. That's all they want to hear. And then, of course, if this family doesn't speak your language and you're not fluent enough, do not have the 16-year-old son who's with them translate, because they're going to put in their own opinion on what their mother or father said. Make sure it's through an interpreter. They've got those beautiful blue phones now that are very easy. I mean, if you have another nurse or physician who treat as language, that's okay, but not a family member. Talking with children can be difficult. So what do? When you walk into a young child's room, don't think you can walk up and just start listening to their chest, doing an assessment and talking with them. It's not going to happen. But if you walk into the room and go, hey, you have a Batman shirt on. I just got one for my grandson. That's the coolest thing ever. And then, okay, sit down, maybe give them a sticker. I always had stickers in my pocket. It was always this great thing to break the ice. I go, look, here's a Batman for you. And then start talking about something else. Then I'm like, okay, let me listen to your chest. You want to hear mine first? Let them touch the equipment. Get on their developmental level. Get to where they understand you and that you're not threatening. Most important thing, get on their level. And then you could play games in order to get through to them. You know, I know where my nose is. Where's yours? Okay, what ear hurts? This hurts. You know, and they're going to start being more open, talk with you. They're not going to be afraid because remember, you're a stranger. If you have a group of people coming to the emergency room in South Florida, as I said, there's a lot of Hispanic people, and you'll never just see one person come in with a child. I'm used to up to 10 people would try to come into the room with them, which, you know, today we can't do that, but you can have more than one. Make sure you're speaking to the person who knows the information. It could be grandma instead of mom. It could be their best friend or their aunt. It could be someone else. So make sure they know which one's going to speak and find out what's going on now. Don't hear what's happened for the last 8 years if it doesn't pertain to what we're looking at. Once we find out what's going on, of course, other information is important. You know, were they born? Were they admitted? You know, have they ever had admissions, injuries, allergies? Of course. I mean, you don't give any medicines without an allergies, finding out about that. You know, any medications they took. So if you need to medicate them with Tylenol, Motrin, whatever, you know when you can give the next dose. And then immunizations. You know, if I have a young child with 102 fever and a cough, I want to know immunizations are up to date. I want to know that kid doesn't have something like pertussis because it's extremely infectious. So immunizations are important. And then their habits. What if you have a child who parent has to run out of the room or go home quickly and you're stuck with the child in the room without a parent? It happens. You know, parents do have other responsibility. I want to know that that kid's teddy bear is the favorite toy. And if they're crying, teddy bear will help them feel better. Or that blankie or that pacifier. Or they need their thumb, so I don't put an IV in that hand. I want to know what their habits are so I can give this child everything they need to feel comfortable and to self-soothe without an IV in the hand, okay? These things are really, really important to understand. With adolescents, you know, it's hard for adolescents. I know I wouldn't be talking in front of my parents. If I was in high school, I was sexually active, there was no way my parents were going to know about it. But if it was something that was causing a frequent medical condition, like if I had frequent urinary tract infections, let's say, and it was due to I was having sexual activity, I would be happy if I could tell the nurse, and if the nurse didn't have to tell my mom, because, you know, my mom would have been really angry. But anyway, so one of the things with adolescents, ask the parents to leave, step out of the room, talk to the child, build a rapport with the adolescent too. Because remember, you're an adult also. So get yourself on their level, whether it's talking about school, music, sports, where they're going to college, whatever. Get on somewhere where they can understand you and that you're non-threatening. And you don't have to tell the parents what they say unless it's something that will hurt them or others. So that's the way that I've done many, young girls have talked to me because I broke the ice and they'll tell me what's going on. And we could give better medical treatment because of it. A lot of times I'll ask, how are the kids in school? I ask the kids, so what grades are you getting? If they'll say, they don't give me an answer, like C's maybe, or those A's and B's or all A's, you sort of know how they're adjusted. Another thing is how the parents and children react. Now, I can tell by putting a child in the emergency room, in a room, you close the door. I'll walk in, mother will be there on the phone, texting away or whatever they're doing. And the kids on the stretcher, taking the otoscope, the little black earpieces, throwing them around in the drawer, alcohol swabs all over, the sheets off the stretcher, and the kids just sitting there and the mother's not paying attention. I will know that they don't have a really good relationship. You brought your kid into the emergency room and the kid's sitting there just doing whatever they want. So that would be a child that if I had to give medicines to, I'd really have to spend some time doing that, wouldn't I? And when I'm doing assessment of the body systems, remember, I'm going to start by breaking the ice with getting on their level, letting them touch the equipment. And then I'm probably going to do a focus of what's going on now. Cough. I'm listening to their lungs first, but they might have to listen to mine first so they don't feel threatened by it, or let them listen to their own breath sounds. So these are things that we can get things done. We need to know what they eat, if they're all vegetarian, they don't eat pork, or if they're allergic to foods. These things we need to know. And if we don't think a kid's getting proper nutrition, we can get an assessment on it. I mean, I know many toddlers, the mother would say, macaroni and cheese, chicken nuggets, and apple juice. That's it. That's all my kid will eat. And I'm like, it's really not good nutrition. It's not getting everything they need. So something that I could tell a physician, maybe they need vitamins. We're going to be doing, as I said, heights and weights, measuring nutrition. Younger children, we're going to do head circumference and abdominal girth, chest circumference. When infants are born, their heads are big and their chests are smaller. By the time they are a year and a half, 2 years old, that chest should be equal to or bigger than the head. And if it's not, something's going wrong. The head is too big. So we're going to investigate that. Their physical assessment, how would I know if they're doing okay on their pulse and blood pressure if I don't know norms for that age group of children? So knowing that maybe a 2-year-old, a normal blood pressure is 80/40, and I get a blood pressure of 50/30, I know I'm in trouble, right? So you need to know normal vital signs on children, very important. We're going to look at the body, and in most of the time, children don't let you do all things at once. A lot of visual. Sometimes if they're sleeping, that's a great time, especially infants, to go in and listen to breath sounds and heart sounds and abdominal sounds. So you've got to take your time and be patient. It's not going to be smooth sailing. Got to go slow and easy. You were told in OB that you do a rectal temperature on newborns because you want to make sure you have an accurate temperature, right? Well, you're actually checking to make sure they have an anus. Not every child is born with an anus. They have something called an imperforated anus. That means they don't have anything at all, and they need to have a colostomy made as soon as possible, okay? Because there's no way to exit anything out of the GI tract. We'll be looking at their neurological signs, if they have the normal sucking and cooing and startle reflexes. And of course, looking at all their measurements. One of the things working in the emergency room, I had to do, of course, as I said, heights and weights on every child. And taking a kid, this kid's probably about 2.5, 3 maybe, putting them underneath that wood plank and banging their head, they're scared of it. So how do I get them to do it? Well, I do me first and I go, oh, my number is 7. I don't know what your number is. You want to see what your number is? See, I'm playing a game. Turn them around. I say, here, hold the thing. Tell me when it just touches you. I go, look, your number is an 8. You're bigger than me. Good job. Give him a sticker. What have I done? I've gotten an accurate height and the kid's still happy. He's not running away from me. Oh, take a blood pressure. There are blood pressure cuffs from 00 to extra large in adults. What one do you get? In pediatrics, 1, 2, 3, 4, and 6, probably the most common that are used. What one do I choose? And as you get into pediatrics, you sort of figure out, all right, which one? And with those electric machines, they're going to have a sundry of different sizes for you to choose. In the toddler preschool ages, I do a lot of the blood pressure D, looking at the dorsalis pedis and posterior tibial artery, because I could distract them. I could get an accurate blood pressure. You put it on the arm, it gets too tight, they don't like it, and they squirm, they cry. I don't want that. Again, we're gonna look at the child up and down and all over. Pain management. Years ago, we really didn't address pain. We didn't think kids had pain. We didn't think their nerves were sensitive enough to have pain, especially the premature children. Well, guess what? They do get pain. And we have done a lot of research to show that. So even today, knowing this and having all of these programs in place to look at pain, we do pain scales on every patient with every vital sign today, okay? That's part of requirements that came through the Joint Commission. So we'll do these assessments. So what has happened is they're giving doses that are not big enough, because we give milligrams per kilogram. We give doses that are proper. We don't overdose these children at all. We wait too long, and then we're not giving, maybe in between medicines, just like Tylenol can work for that, and then evaluating their pain. There's all sorts of pain, just like there is in the adult world: chronic, recurrent, resistance. Could be from medical procedures, it could be bracelets, it could be putting a cast on. Ear pain, probably one of the biggest pains kids have. And ear pain, they be crying, it hurts so hard. It's one of the things I see a kid, my ear, and of course I'm running for the Motrin as soon as I can. So how do we evaluate the pain on these children? We need to say, is it 0 to 10? 0's no pain, 10's the worst pain in the world. Well, 2-year-old will go, huh? Well, a 2-year-old will be using this FACES. This FACES scale is not used till they're preschoolers, ages 3, 4, up to age 8. Before that, we use something called a FLAC scale. And the FLAC scale gives points for their facial expression, their legs movement. Now, if kids in pain, those legs are going to be moving, they're going to be wiggling, they're going to be crying, and there's no way to console them, no matter what you do. Even putting a pacifier and trying to themselves soothing, it's not going to happen. And then at age 8, according to your book, is when we start the numeric. 0's no pain, 10's the worst pain in the world. But children can use FACES scale when they turn 3 years old, and the FLAC scales we use a lot also. And FLAC can be used for nonverbal children too, like your cerebral palsy who doesn't talk. It can be used for an 18-year-old, an 8-year-old, doesn't matter. It's used for many children. So I said there's all sorts of pain. And what's great is there are different checklists. There are checklists for those non-communicating or children who cannot, communicate properly. And we can assess pain really well today. Now, one of the things is, look at this, cultural differences. And what does that mean? Well, I've had many times, and it's more than once or twice, I've had parents come in with a child with a broken arm or leg. And I say, I'm going to give your child 1 shot of morphine because they're going to put a cast on and it's going to hurt to manipulate that arm, that leg. And the parents go, no. He doesn't need it. Right, buddy? You're not in pain, right? You don't hurt. You can man it up. And I'm like, you realize this is really going to hurt. Well, they're going to get addicted on one shot. I'm like, that's not possible. And a lot of it's cultural. So understanding and trying to explain it to them about it, sometimes they'll do it and many times they won't. I mean, at least I'm going to give them Motrin. And then we can give pain medicine all the time, but if we're not treating the holistic person, it's not going to be as effective as we can. Now, distraction is awesome. Giving them something to play with, an iPad, bubbles blown on them, music, looking at stickers, mommy in the child's face and giving them kisses. Distraction, oh my goodness, helps with pain medicine, of course. Now, one of the things that is quite amazing to me is even my grandson. He needed to be circumcised. He had really tight foreskin, so it had to be done early. He had it done with a pacifier with just sugar water on it. There is a study by Harvard neurophysicists that said sugar water on a pacifier had the same results of giving a child morphine, and it is effective. I mean, there's really good evidence-based subjects about that. And then this little baby, Kangaroo care, skin to baby. I've seen really irritable little premature babies that can't get, they're fussy and heart rates are up and you can see they're miserable. Mommy comes in, puts them to skin, all of a sudden their heart rates come down, their respiratory rates come down, and they just relax and they sleep. So Kangaroo care is another one. Tylenol is another one that we can give, hot packs, cold packs, positionings. Now, non-steroidal anti-inflammatory, Motrin, we do not give that to infants until they're 6 months old. There is some bleeding coagulopathy, something with platelets that affects younger children. So a child must be 6 months old before we'll give ibuprofen to them. There's other different things like this topical cream that's on this girl's arm. She's smiling. They're going to be coming in doing labs on her any minute. And she's smiling. Why? She has a little tegaderm with numbing cream called Emla underneath. It's numb. She knows that when they take it, clean it off, put a needle in it, she won't feel pain. She'll just feel the touch, but there'll be no pain. So again, atraumatic care, right? Children get pain all different ways. I said ears, I think, are the worst. Even immunizations can cause it. We know sickle cell children do get a lot of pain. So they do get some really good IV morphine or even Dilaudid, depending. And we know that treating the pain is what we have to do for children. Take care of their pain. Don't let them hurt. That's always been my thing. I don't like seeing children in pain. So how are you doing so far? We're going to do the Kahoots and then we're going to be done. Let me pull it up. So go to Kahoot.it on your cell phones. Enter 259264. Enter your name. Now, if you enter your real name, and if you need me to come back and do one-to-one with you, I can see what questions you got wrong to try to help you understand them if you want. Anybody else want to join? There we go. Let's get going. So we're out of here on time, a couple of minutes before. From a worldwide perspective, infant mortality in the United States, that means how many infants up to 1 year old die? How many in the United States compared to everywhere in the world? It's the highest. We have more infant death here in the United States than many other countries of the world. We have some catching up to do. We're getting there, but still we need a lot more work. The leading cause of death from unintentional injuries in children. Now I'm going to give you some stuff that's going to be off of next week, but as you're doing your readings, this is a reinforcement for you. These are some concepts that you need to know. So I've put them in here. There's 34 on this Kahoot. I usually do 40 to 50, so it's a smaller one. And it is motor vehicle fatalities. And this doesn't mean just in the car seat, in the car, or in the car without car seats. This is cars running over children. Remember I told you I just came, the last job I did was 10 years at a trauma center, Nicholas Children's Hospital, Miami. And I was a trauma nurse. Children would come in, the next door neighbor, the parents themselves had ran over their kids. And some of them had no injuries, amazingly. And then of course, some had really massive internal injuries. So it is one of those unintentional things. Which statement is most descriptive of pediatric family-centered care? What does that mean? Family-centered care. Because we don't just take care of children, we take care of families. And families could include aunts, uncles, best friends, grandma, grandpas. I've taken care of all of them. And the family is the one constant in their life. We know as they get older, they break away slowly, but family is that one constant. The major cause of death for children older than 1 year old is. Remember, these are my dive bomb kids. These are the toddlers. Still remember my grandson doing a dive bomb from the couch to the hassock, and he missed it and head hit the floor. Had a big bop on his head. Never did it again, but he had to try it. Unintentional injuries, yes it is. Didn't mean to, but he did. The nurse caring for the child in pain understands that distraction. As I said, distraction can be many, many different things. You know, when I worked newborn ICU, I constantly had music playing on the night shift. And my babies would sleep all night long. It was the best thing. But remember, it must be developmental appropriate. If it's not developmentally appropriate, the kid doesn't understand. It's not going to do anything for them. But if they get it, they understand it, they're going to focus on that, not their pain. And what type of play are children engaged in similar or identical activities without organization or a mutual goal? That means nobody wins. I mean, children learn a lot through play. That's the way they learn when they're kids. And that is called associative. These are some things that you do need to look at, especially now you're looking through, you know, going into the toddler preschool ages. It's going to be some good explanations. Which statement best describes the process of critical thinking? You go into nursing school and they say you need to think critically, and you're like, gee, I don't know if I can do that. Well, you all go to the grocery store to make dinner, and you've checked your cabinets, know what you need, buy what you need, come home and make it. Isn't that critical thinking? Yes. and it's purposeful and it's goal directed. So if we can remember that, make it easy and stop thinking it's so hard, you'll do a lot better. What is probably the single most important influence on growth at all stages of development? Nutrition, nutrition, nutrition. Without nutrition, you don't grow. Your mind doesn't grow. You're going to be delayed. Frequent developmental assessments are important for which reason? Like, why do we want to know if the kid can roll over and sit up or walk or crawl or take their fingers and grab things? Why? So if we're looking at it, we know that there's things that they need to do. And if they're not doing it, we're seeing those delays. And what do we do to correct that? Well, we're going to do early intervention. You know, it's going to be physical therapy, occupational therapy, speech therapy. What do they need? We're going to get it for them. Which function of play is a major component of play at all ages? What do kids do when they play? You know, they take it, they look at it, they roll it, and of course in the mouth, right? That's how they explore play. And that's called sensoromotor activity, okay? What does it feel like? What does it taste like? And then we're going to move it around and we're going to play with it and be creative. 3 children playing a board game would be an example of what type of play? That means there's a goal here. I was playing Paw Patrol game with my grandson, me and Pop. The kid won. He's 5. I'm like, my goodness, I need to win. And Pop was so angry that he won. He didn't. Cooperative play, yes. There's a goal. He got all the things in home the way he should. The head to toe direction of growth is referred to as head to tail. And that is called cephalocaudal, cephalic head, right? Caudal to the feet. So it's going to head up and then to walking, cephalocaudal. What is the single most important factor to consider when communicating with children? We want to know their developmental levels. We know how to approach them so that we can get things done a lot easier. What 2-year-old child pain assessment tool should the nurse use? We have FACES, we have Oucher, we have numeric, we have FLAC. Which is going to be used? 2-year-old. So a FLAC tool is up to the age of 3. At 3, it starts FACES. Remember, preschool starts at age 3, and that's going to be your FACES. And at age 8, it's numeric. At 6 months, an infant's birth weight should do what? Again, this is part of next week that's going to come up, but these are concepts you're going to see intertwined in questions you need to understand to be able to answer questions. At 6 months, it doubles. At 1 year, it triples. If it's not that much weight, the kid needs more nutrition. We can increase calories in formulas or even put fortifiers in breast milk. If at a year they're too big, we can stop giving them extra juice or whatever. So it's something we use as that baseline to treat children. The first expected fine motor developmental milestone for an infant begins with. There are two types, fine motor and gross motor. Fine is F, think about fingers. Then there's gross motor, think G, get up and go, 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 like Paw Patrol, okay? So fine is fingers. What do they do first? It's a reflex. You put your finger in their palm and they'll close it on a reflex. That's the first. Then it's voluntary palmar grasp. Then it goes into crude pincer, which is fingers, and then it's fine pincers. Then they're going to put stuff into a container and then build a block of two. By age of 1, you're going to see this in your reading. Part of fine motor, what a child should be able to do. An 8-month-old infant should be expected to perform which fine motor skills? Again, with their fingers, what do you think they should be able to do? So they should be able to grab that rattle voluntarily and then a crude sort of smush to get those little Cheerios off the high chair, okay? That should be about 8 months old. It's going to be the hardest part of pediatrics is infants and learning what they should do at what age. The natural physical developmental sequence that most children follow is what? And this is motor. What should they do? What's the first thing they should do? They should be able to lift their head first. That's the first thing they do. Then they roll from front to back, back to front, then they're up on their knees, creeping backwards, forwards, standing up, walking around, and then walking by age of 1 is what they say. Again, it doesn't matter if they're not there at age 1 or if they're earlier. It's just they're quicker or slower. Which behavior indicates that an infant has developed object permanence? What did I say that was? So this is when you take an object away and it's somewhere they can't see it and they still look for it. They still know it's going to be there. Okay, it's object permanence. It's permanent in their brain. They can remember it was there. You think that infants don't understand. Let me tell you, infants are extremely smart. I worked with them long enough to tell you that. In general, an infant should triple their birth weight at what months of age? And that's at 12 months. Double at 6 months, triple at 1 year. Very good. You guys are going to be ahead for next week. Perform a head-to-toe assessment on a toddler. Most important to consider before beginning the examination. Remember, a toddler is ages 1 to 3. Before you go in and try to listen to them, touch them, take a temperature, what should you do? And get in there on their developmental level, and then you can do almost anything you want and keep them involved with you. Even 1, 2, and 3-year-old children will be able to push buttons and do things for you. They're smarter than you really think. According to Piaget, toddlers are in the what developmental stage? Now we're going to learn more about this next week. I'm just introducing you into these things that you are going to see. Now, if we have studied or we know autonomy versus shame and doubt and trust versus mistrust is Erickson, okay? Piaget is all about formal operations and sensor-motor. Sensor-motor, again, is touch, mouth, and moving. That is Piaget. They're starting to experiment. That they can see things and how they're working. That's cognitively teaching them. A car, you put it on their wheels and roll it, it's going to roll. Sensor-motor, okay? And we'll discuss it more next week. Just opening it up to you now. Which intervention helps a hospitalized toddler feel a sense of control? You know, it's hard enough to take a toddler, ages 1 to 3, you know, take them on vacation. They're not going to sleep. They don't nap. They don't eat right. Put them in a hospital. Okay. How can you make it easier for them? And it's keeping them on their same routine, same food, same routine, bath time, the same time, you know, getting them their jammies, putting them in their clothes, whatever the routine is, it gives them comfort. They know that's what's supposed to happen. And if it doesn't, they're confused. They just don't understand why. All children reach developmental milestones at the same age. Yes or no? Absolutely not. Everyone's different. You know, most children are up and maybe walking by 12 months old. My grandson, he never walked at 12 months age. He never walked. He ran at 15 months. But that is all different, and it's okay. As long as you're moving forward, it's normal. Immunizations for a 4-month-old infant, which action should the nurse take to provide a traumatic care for that infant? What do you do so that needle going into that leg doesn't hurt? And that's that sugar water on a pacifier. It's just like giving them morphine. Like I told you, my grandson had a circumcision that way. And I heard him cry for a second, but it was brief. It was less than 15 seconds, which is normal. Self-soothing pacifier. Which of the following immunizations could be administered to a newborn? You're going to see 2 big pages of immunizations. Do not get overwhelmed. There are certain ones you need to know about. This is one of them. This one is given in the hospital before they're discharged, usually. And that's hepatitis B. DTaP is given at 2, 4, and 6 months. And polio and MR are up the way. So immunizations, Hep B, you know it's at birth. The normal heart rate for an infant is, what did I tell you? Now you need to know this if you were given digoxin to an infant, right? For an adult, you count it. If it's less than 60, you don't give it. Well, what if the heart rate on an infant was 100? Do you give it or not? Is that normal? Well, no, it's not, and you're not going to give it. That's why you need to know what these normal vital signs are on different age children. Good job. What is the preferred site to give an injection to an infant? Do you remember pharmacology? And that's vastus lataris. And it's not called, upper calf is the back of the leg, lower leg. So no, it's the upper outer thigh, and it's nice and meaty and they move it a lot. So it's a good place to do it. The death of an infant under 1 year old with no known cause, what is that called? You know, knowing the signs and prevention of SIDS death, you need to understand. We'll talk a little bit more next week. The one thing I didn't know until I started teaching was that SIDS deaths are more frequent in males than females, which I didn't know. I mean, I know that breastfeeding decreases it over bottle feeding, but I didn't know males had more SIDS deaths than females. That I didn't know. And there's no smoking and co-sleeping and all of that good stuff, but you'll be reading about it. The Vietnamese mother of a child avoids eye contact with a nurse, considering cultural differences. Why is she doing that? Why isn't she looking at you? I mean, these are some of those little things with culture that you need to understand maybe why she's doing that and ask. And it's showing respect. It's part of their culture. It's not that she doesn't want to look at you or feels littler than you. It's just respect. A child from Mexico is being hospitalized for a serious illness. And the father says the child's being punished by God. Why does he say that? Absolute common belief of the Mexican culture. They believe that illnesses are due to being punished by God. It's part of, you know, their cultural system. Which term refers to an individual's life when he or she is more susceptible to positive or negative influences? What is that called? And that is called sensitive periods, okay? So again, you're going to see these terms, pay attention to them as you're going through your readings and your active PowerPoints, okay? What is characteristic of the pre-operational stage of cognitive development? This is Piaget again. Remember, he talks all about thinking, and he talks about thinking of the young children all the way up to adults and how to interpret those things. So pre-operational is your younger children. They have to see it to understand it. As they get older, they already understand it, and then they could go another step with it, you know, do something more with that information. But these young children just know if you put the car on the ground with the wheels down, you can roll it. If you turn it upside down, it doesn't roll. It's simple as that. And last question. According to Kohlberg, children with moral reasoning, what is the preschooler stage of moral development? And again, we're going to talk more about this, you know, and different examples of this will be given again during that preschoolers ages, because we're going to do preschoolers next week. And again, Kohlberg talks about good and bad and a consequence for each. Basically, that is Kohlberg. And then different levels according to the age of the child. Let's see how we did today. Number 3, Amber. Good job, Amber. I know it's hard. Annie. Number 2. Number 1. Mia. Good job, Mia. Number 4, Shah and Angela. Excellent. Good job today with that. What I'd like you to do is sign your attendance attestations. Remember, you need 2 points of reference for you to get credit for attendance this week in Canvas. So that's the way you do it. So go into your module, go to attendance attestation and sign it for me. Don't forget. I will be looking this week and making sure that it is done. I don't want anybody to be taken off without notice. Any questions from anybody?
So you said for the attestation, Ms. Bogart, we need to do 2?
you do week 1.
Yep.
And your second form of notice is when you do your discussion question. Those are 2 points of contact in your Canvas shell for this week.
For the
And
attestation.
attestation and your discussion question. Yes.
Okay, thank you.
So I will be giving you your recording